the word syncope ablation comes up. Now, you're an electrophysiologist, so you're a cardiologist who works in the cath lab doing procedures and operations. Tell us, what is a syncope ablation and who might benefit from it?
Good question. And I'd first of all qualify the answer by saying that this is not a procedure that currently has gained widespread popularity. Certainly within the UK, it's not in any guidance that we should be offering this procedure. But my own personal view and feeling on the basis of my background, which is where I did a PhD in the role of the autonomic nervous system within the heart and its role in promoting heart rhythm abnormalities, where I was able to study the location of the nerves within the heart that could lead to the heart's stopping. So the cardiac nervous system is called the intrinsic cardiac autonomic nervous system, and that resides in certain fixed areas within the heart. Some of those areas, which you can imagine are very richly innervated with what we call ganglionated plexi, which are the bodies of the nerves with the tentacles spreading out to all the relevant areas of the heart. Some of these ganglionated plexi are located in specific anatomic regions in the heart that can supply, for example, your natural pacemaker site, your sinoatrial node or your sinus node, and that can suddenly and abruptly stop beating, which is should be the source of all your heartbeats, can suddenly stop beating with a strong vagal response in vasovagal syncope. So patients who have the cardioinhibitory form of syncope, whose heart can stop beating with a vasovagal reaction, typically are given pacemakers. And so I would not deny a pacemaker to a patient, for example, who may have another reason for pacemaker. For example, the electrical system of the heart is a bit sluggish and they typically are a bit older. But let's say, Mel, we had a 21-year-old patient who is super young and only has syncope with needles. And so every time when she has to give blood, she has vasovagal syncope, but she stops her heart for 16 seconds and she faints. Is that a patient we want to put a pacemaker in? Now, the guidelines would suggest if it's an uncontrollable recurrent episode that she cannot stop, then, in fact, there are no guidelines, but that could be a logical thought process to stop her fainting, because literally in this group of patients below 40 years of age, there are no guidance about how to treat their episodes of recurrent syncope. So the technique that has evolved on the background of understanding that in the heart there's nervous centers of tissue that can lead to strong vagal inputs into the sinus node, but a secondary relay station called the AV node can be ablated. If you can find them and you can ablate them, then you can abolish the vagal response. So these patients, after an ablation procedure, which is called the syncope ablation procedure, may not be able to slow their heart rate down anymore through a keyhole cardiac surgical approach, which is done under general anesthesia. It takes 2.5 hours and it's a one-off procedure, as opposed to having a pacemaker, which is a permanent device that sits on the left side of your chest, just below the collarbone, with 2 leads in the heart or 1 lead in the heart, which stays there for the rest of your life. So you're 21. If you live to 85, you might have a need for 7 or 8 box changes with the generator running out every 10 to 12 years.
Yeah.
And that is a significant surgical morbidity going over the course of one's lifetime.
So a syncope ablation is an operation that you do. It's for a very select group of patients. So you need to, obviously it won't be for everyone that's coming in with vasovagal syncope, and it won't be for every patient coming in with cardioinhibitory vasovagal syncope. So you would select them carefully, and they come in and they have this operation. And these are people for whom you would want to avoid a pacemaker. You said it's not a procedure that's gained widespread popularity and it's not in the guidelines. So if a patient thinks that it's something they may benefit from, or if you see a patient and you think they may benefit from it, how do you decide to go ahead?
So there are two aspects to this question. The first is whether or not I decide with my Syncope hat on. So I currently lead the Imperial Syncope Service, and as an electrophysiologist, I also do these very rare procedures. The first thing to decide is whether or not the patient can get away without a pacemaker and without a syncope ablation, and that is to say, to maintain really good syncope hygiene, to avoid the triggers, to really do what they can, to drink, to hydrate, to compress, to take drugs even if their blood pressure is low, to augment their blood pressure, to prevent the reflex from happening. In those patients who have tried all these maneuvers and fail, and they're still getting recurrent syncope, those are the patients typically below 40 years of age who want to avoid a pacemaker that I would take to the next level, which is a discussion with my electrophysiological colleagues where I work in Imperial to gain general consensus, because this is not a procedure that we do commonly, and as I say, it's slightly outside of guidelines. And so we go to a second committee after it's approved by the electrophysiology cardiology committee, and we go to a second committee called the New Interventional Procedures Committee to gain advice about whether we should proceed in this patient.
Okay.
Now, obviously, there's a third route into syncope ablation, which would be a research trial, which we're setting up to try and do this in a context of research. But this would be a sham experimental controlled trial.
Yeah. Okay. So this is a procedure that you'd have to go through some hoops. So it's not something that everybody would get. It's a carefully selected population.
Correct.
And one final question is, are there any side effects to having this operation?
So almost certainly with the syncope ablation, because we're effectively denervating the vagus to your natural pacemaker, the vagus is the brake of your heart, and it causes your heart to slow. You will wake up from the operation with a high resting heart rate. So if your heart rate at rest, Mel, could be 70 beats per minute, you might find that for 3, 6, 9 months after the procedure, you might be sitting closer to 90 or 95 beats per minute. And this is part of the outcome that we would expect when we denervate the heart.
It takes away the nerve, the vagus nerve supplied to the heart, which is what causes the heart rate to go low. But what we've just been hearing is that this procedure is not something that's routinely offered. In fact, it's very, very rarely offered, and it's something that would have to go through a lot of specialist discussion and multidisciplinary meetings to be approved as an almost experimental treatment for now, at the moment, at present anyway. But it certainly sounds like it's something that's got promise, and we should be looking out at research studies and trials to see the outcomes, and you're running one here, so we'll keep our eyes posted. We'll keep our ears posted.